Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Community Liaison, and it's my pleasure to serve as host of the CGNE Seminar Series. I'd also like to introduce Jenny Rank, CGNE Education Program Specialist, who is helping with some of the technical aspects, as well as helping with facilitation of the Q&A and discussion portion of the session. Today's seminar on the role of the Ombudsman and the need for partnership will be presented by Dr. Diane Berish, as well as Dana Gregg and Penn Pendleton. Before we begin with an introduction of our speakers by one of our affiliated DNP students, we do have some announcements and disclosures. This seminar is being recorded. We do ask that you stay on mute. And if you'd like to be unmuted to ask a question aloud or share a comment, please raise your hand or put a note in the chat, which we will be monitoring. Please enter any comments into the chat, as well as questions into the Q&A feature. These will be addressed during the Q&A discussion portion of the seminar. The post-event evaluation link will be placed into the chat at the end of the seminar. It will also be emailed to you within 24 hours. The evaluation must be completed within 1 week of the seminar. While this is required for RN seeking contact hours, we ask that all attendees complete the post-event evaluation, as this provides us with data as well as that will help to inform us about our center activities, as well as for our age-friendly care PA initiative. Contact hour certificates will be emailed to registered nurses, meeting all requirements within 1 month following the seminar. Penn State Ross and Carroll Nese College of Nursing is an approved provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. At this time, presenters, organizers, and content specialists have indicated no conflict of interest. This activity has been submitted for 1 contact hour for participants who hold a valid RN license, attend the entire session, and complete the evaluation. Partial contact hours are not awarded. This program is being provided by the Penn State Nese College of Nursing, Teresa Nese and Helen Diskovich Center of Geriatric Nursing Excellence, in collaboration with the Center for Nursing Research and Age-Friendly Care PA, which is funded by HRSA. If you have any questions or need any additional information, please feel free to reach out to cgne@psu.edu. And now I'm pleased to introduce one of our newest CGNE affiliated graduate students. Amy Crisatello is in her first year of the DNP Clinical Leadership Program with a focus on mental health and access to care. She brings a wealth of expertise working with older adults, including her work as a psychiatric nurse practitioner in long-term care with Sunpoint Health. Thank you, Amy, for introducing our speakers today.
Thank you, Janice. It's my pleasure to introduce Dr. Diane Berish. She is an assistant research professor in the Nese College of Nursing. She serves as the college statistics consultant and formerly worked in long-term care setting as an activities director. Her research interests are long-term care, care quality, and policy. I'd like to introduce Ken Pendleton, who began his career as a senior care advocate over 30 years ago and a nursing home administrator in the state of Nebraska. There he met with a succession of increased responsibilities, but never lost sight of those he and his team served, the older adult. Strong family connections involving his grandparents continue to sustain his sense of dedication and purpose to another facet of the long-term care continuum, home care services. In this capacity, he served as an operations officer and administrator for a multi-site Nebraska-based provider of home care services. These skills were later utilized in Central Pennsylvania, where he served as Director of Outreach, Recruiting, and Quality Improvement for a locally franchised home care organization, which served over 300 clients at any one time. Today, Ken continues as the Director of Center County Office of Aging, which administers federal, state, and local funded and sanctioned senior care programs, including, among others, the Pennsylvania Long-Term Care Ombudsman Program. And also like to introduce Dana Gregg. Dana has over 20 years of experience working in long-term care. Throughout her professional career, Dana created and implemented diverse life enrichment and dementia engagement programming to support person-centered care. Using innovative design, she developed a wealth of programs to combat loneliness and social isolation. Dana worked closely with Penn State's College Health and Human Development to develop a successful internship program where she mentored over 100 students in pre-professional experience. As a proud Penn State alumna of the College of Health and Human Development, she focused on adult development and aging. She is a certified activities director and a certified dementia practitioner. Dana joined the Center County Office of Aging in May of 2021. As a certified ombudsman coordinator, her responsibilities include overseeing the county's 15 personal care homes, 6 nursing care facilities, and 2 domiciliary care homes. In addition, Dana is Pennsylvania Medicare Education and Decision Insight Coordinator, known as PA Medi. Dana looks forward to using her advocacy skills to empower seniors and helping Center County residents make informed decisions about Medicare.
Okay, and so now we're going to begin with Dana, right? Mm-hmm.
Good afternoon, everyone. Thank you, Amy, for the introductions. I am going to just minimize this and I'll begin. Well, first off, I just want to say that often when we talk about ombudsman, it's a word that people are not familiar with. And that is one of the things that I've discovered along the way in my role as an ombudsman. But the word ombudsman is a Swedish word and it means citizen representative. And the Pennsylvania ombudsmen are trained to advocate, to resolve complaints on behalf of people who receive long-term care services. And the mission is to advocate for those who can't, support those who can, and ensure all long-term care consumers live with dignity and respect. In Center County, we have 6 volunteer ombudsmen, and including myself as the staff ombudsman, with combined experience that makes just over 70 years. So we have people in Center County as far as the ombudsman who have quite a wealth of experience with advocacy. Ombudsmen empower residents to self-advocate by educating them on their rights under federal and state law and advocate for those who are unable to advocate for themselves to ensure they receive the highest quality of care. Ombudsmen also work to bring about change that improves care at the local, state, and national levels. And I'm trying to advance my slide. Are you guys still there with me?
Yes.
Okay. All right. I think. All right. So some of the rights that I wanted to talk about with you this afternoon are the rights that are under the federal and state law. And I just listed a few of them. And if you want to learn more, I would encourage you to look at one of the websites that I think is an excellent resource, which is the National Consumer Voice for Quality Long-Term Care. So please take the time to read more in detail about the resident rights because they're pretty encompassing. The few that I wanted to share, the first one is the right to participate in their plan of care. So residents do have a right to be informed about their plan of care and be involved in that in all levels. They also have the right to refuse treatment and to be informed of any changes in their medical condition. Another right that's really important is the right to be able to voice their grievances without fear of retaliation. This includes prompt efforts by the facility to resolve grievances. And as an ombudsman, that is one of the things that I encounter fairly frequently, which is residents do express their concerns, but they're often hesitant to go further with their complaint out of fear of retaliation. And that's where we come in and talk to them about their rights so that they can get more comfortable with wanting to be able to voice their concerns. Another right I wanted to share is the right for individuals to make independent choices. This includes choosing a physician, to making independent decisions such as what to wear, how to spend their free time, to participate in resident council meetings. Another right is the right to privacy and to be treated with dignity and respect. This includes privacy in treatment of care and personal needs, including the right of confidentiality. And the last one I wanted to talk about is the rights to pertaining to admission and transfers and discharging. This is often one that that we are advocating for residents in long-term care is the right to appeal the process of discharge. Something unique in Pennsylvania is the peer program, and I'm pretty sure that probably a lot of you on the this meeting today haven't heard about this, so I thought it would be important to mention. And the peer program stands for Pennsylvania Empowered Expert Resident Program. And peer are long-term care residents who are trained to self-advocate and empower their fellow residents to improve quality of life and quality of care in long-term care facilities. Peer is a partnership between residents, facility, staff, and local ombudsmen. And the philosophy is that it's resident focused. It gives residents a voice, provides a connection with ombudsmen, volunteers, and other peers statewide, and provides residents with an opportunity to stay productive and involved in their home. To become a peer, residents attend a 5-part empowerment training session with a graduation ceremony. In Center County, we have 3 facilities that do have active peer groups. That is Center Care, Juniper Village, and Windy Hill. And peers have brought about positive culture change that significantly has enhanced residents' relationships with care providers, as well as enhanced quality of life. And this is a great time to be having this session because we are smack in the middle of October, which is Residents' Rights Month. And the theme this year is Reclaiming My Rights, My Home, My Life. And it acknowledges the impact of this past year on residents and highlights the need for residents' rights to be recognized, recovered, and reasserted. It emphasizes the recognition of the long-term care facility as the resident's home and the importance of residents reclaiming their own lives. The theme focuses on raising awareness of federally mandated residents' rights by also underscoring the need for dignity and self-determination for all residents. And I did mention earlier consumer voice. And if you visit that website, there's a lot of information and resources that I think would be helpful for everyone to take some time to read about as far as Resident Rights Month. So I'm going to pass this on now to Ken.
Okay. Thank you, first of all, for the invitation to be a part of this panel. We're a privilege to be really the local office, area agency on aging office through the Center County Office of Aging. And my name is Ken Pendleton. I'm the director there. And as my introduction said, I've got quite a background of taking care of seniors and being a senior care advocate. So next slide, please. Dana just gave her local perspective on how we approach our community and looking to find resolutions, providing advocacy, seeking dignity and respect for our residents, and empowering them through understanding their rights. Next slide. The history of the Ombudsman program is actually older than some might think. The actual beginning of all of this was the Older Americans Act in 1965. It wasn't, though, until 1972 that the long-term care ombudsman feature was added, and it was funded through what's called the federal Title III funding program. Although it's federally funded, it is state administered. And so that's where we come in, is that we administer these programs under the auspices of the Pennsylvania Department of Aging Long-Term Care Ombudsman Program. So we're the local focal point for the Ombudsman program here in Center County. Next slide. What's interesting as of late is that there's been a reauthorization of the long-term care ombudsman program in 2016 through the Older Americans Act. And what it has established is a recommitment to our citizens and our older adults' independence and dignity, empowerment and understanding of their rights. However, there were some new commitments made through this reauthorization. And the first is that the Ombudsman program has established a more delineated organizational structure from the federal through the state and local programming, and the function determinations have been established, which has further refined each participant's role and scope. They also committed, made a new commitment towards serving all long-term residents regardless of age. And so anyone in the long-term care continuum is served by the long-term care ombudsman, even though they may be under the age of 60. This is a unique issue for our office because almost without exception, we provide services through the Center County Office of Aging to those 60 years of age and older. Another commitment is access to records. The ombudsman has now been empowered to have unfettered access to long-term care records at any skilled nursing facility, any assisted living, personal care home facility. And so they have that access. Also, a new aspect to the reauthorization is analyzing the best practices of the long-term care ombudsman program and integrating those new practices through a learning process into any new practice. Another commitment is that the funding for the long-term care ombudsman has been officially stabilized under Title III, whereby no less than 99% of the prior year funding can be provided to any area agency on aging. Another thing that's maybe new to some of you is that the reauthorization is putting a higher emphasis on the long-term care ombudsman helping people to transition to a home care. And so when you see announcements about the long-term care ombudsman, you think of the long-term care continuum like a skilled nursing facility, personal care home, but now there's a title that says "and other," which includes now home care services, a relatively new component of the long-term care ombudsman, but still emerging as a function of that position. Next slide, please. So since the reauthorization, In 2017, there's been quite a myriad of accomplishments. You know, over 400,000 cases completed throughout the United States. The resolution of over 200,000 complaints. 68% of the nation's long-term care facilities were visited quarterly during 2017. 30% of all assisted living facilities were visited. And then also, what's an interesting, I think, new aspect of this is over 127,000 intake and assistance consultations were made with long-term care facility managers. And so the intentions of this is to help incorporate recommendations to the facility managers for best practices. And then finally, over 21,000 resident council meetings were conducted through the year with the Ombudsman in attendance. Okay, next slide. During these consultations and activities, these are some of the top concerns that residents expressed. And that was evictions, medication errors, food quality choice, and it was an issue. Maybe the physical facility, whether it's adequate, our call bells and response for appeal for care done in a timely manner, disrespectful treatment issues, roommate issues, quality of life issues. And so those are the primary concerns that the Ombudsman finds themselves embarked in, at least during 2017. Next slide, please. So this brings me to my focus and why I felt it was important for us to express why the long-term care ombudsman program is important in Center County, is that we serve as a local source of advocacy for our community seniors. We take that role very seriously, and it's very important to us that we're able to advocate for them in the long-term care setting. It's important because of the dedication towards providing a local advocate towards helping those who may be helpless. That's another aspect of this that we take very seriously. There's many that can advocate for themselves, and that brings us to the next. As senior advocates, we provide dedicated service on a personal basis, and we're working to helping each person in need who cannot help themselves. And I guess you could say, in summary, our function locally is that we translate national programs into local and personalized action, care, and service. Thank you for allowing me to present this. I guess, Diane, you're up next.
Thank you. I appreciate it. And thank you both for being here today to present your views from the Ombudsman Office. Okay. All right, so can everybody see my slides? Mm-hmm. All right. So hello, I am Dr. Diane Berish here at the Nese College of Nursing, and I am here to talk to you today about an article that I published in 2019, which was looking at some data analysis around the impact of long-term care ombudsman presence on survey outcomes in long-term care facilities. So first, I'd like to thank the CGNE team here at the Teresa Nese and Helen Diskovich Center for Geriatric Nursing Excellence. So Dr. Marie Boltz, Dr. Donna Fick, and Janice and Jen for helping get this talk organized today. I wanted to thank again Ken Pendleton and Dana Gregg for coming here from the Long-Term Care Ombudsman's Office. And thank you all for attending to listen to us speak on this important topic. So just to give you a quick overview of what I'll be talking about today, I'll review a little bit about the survey process in long-term care and what that entails, just for those of you who might be unfamiliar with that here in the audience. I'll go over our data and analysis techniques that we used in this article to answer our research questions, present those results, go through a little bit of discussion, some of the limitations on those results, and then hopefully we'll have some time for questions for everybody here. So just to give you a little bit of my background, how I became interested in this topic, as I said in my introduction, which thank you, Amy, for that, I am a former activities director. So as Dana also knows, as an activity director, one of your responsibilities, or at least in our facility, one of the responsibilities for the activity director was to run the resident councils. I was often involved in, concerns, or it might rise to the level of a complaint, and that might need the intervention of the local ombudsman to come in to help facilitate the dialogue around whatever issue was going on. So that's sort of where I come from on this issue. But just to give you a little bit of an overview of the survey process in long-term care, nursing homes are inspected regularly by the Pennsylvania Department of Health. And if you go to their website, there's a whole host of regulations, both federal and state, that nursing homes are required to follow. And the survey process is just about ensuring that nursing homes are doing the job that they have been charged to do, right? So making sure that they are following all of these federal and state regulations in order to be a licensed facility. So there's a whole host of information out there that you can look to see exactly what nursing homes have to follow. And the outcome of this survey is facilities may be given a deficiency if they are found to be lacking in a particular area of care. That comes with what's known as an F tag. So that's defining what exactly the deficiency is about. It's given a category. It could be any of those concerns sort of that Ken had gone through, quality of care, respect, dignity, facility issues, administration issues. And these F tags are also given a scope. So how many people does this affect? How many residents? And a severity level as well. So these survey outcomes are publicly available. So if you have ever gone to Nursing Home Compare, if you were to pull up any of the facilities in this area, you could look up to see what the survey results were for the last survey that came through. So survey results are publicly available, and they have some potentially serious outcomes for each of these facilities once they have been given a deficiency. These outcomes could be financial in nature. If they've had a particularly poor survey, that could affect somebody's decision whether or not they want to move into that particular facility. It could result in fines. It could result in reduced reimbursement rates if there is a particular area where they have received a deficiency that is then tied back to reimbursement rates. It also could have legal implications because these survey results and deficiencies that were received could be used as evidence in malpractice lawsuits should one of those arise. So regulation and oversight is absolutely necessary, but what one would hope to see is that that process is applied consistently across states and also across facilities. So prior research has found that there is significant variability in how the survey process is applied across states. And what we were kind of looking to see in this particular study was, is ombudsman presence or not, perhaps a potential source of variability within a state? So if an ombudsman is present during a survey, does that introduce a within state source of variability in how the survey process unfolds? So ombudsman presence could impact a survey either positively or negatively. We really didn't have a strong opinion about that either way going into this study. On one hand, the ombudsman could serve to alert the survey teams to issues that they may otherwise not have noticed or not had detected. So that could result in either more deficiencies, just a number or a wider scope, or an increased severity score. They also could have the opposite effect, that maybe they help to identify and address issues prior to the survey actually even happening. And so the nursing home, the facility is in a better situation overall. And so they have a better survey outcome. Or also during the survey process, they could advocate for any kind of quality improvements that are already ongoing and have already been implemented, again, thus ending in a more positive survey outcome than otherwise may have happened. So the data we used for this analysis came from the Certification and Survey Provider Enhanced Reports, or the CASPR data set, and combined that with the Area Health resource file. And this was done as a facility level analysis. We had data from 2009 to 2015. We limited the sample to freestanding nursing homes who had 2 or more surveys that were completed within that 6-year time period. And that resulted in 95,237 surveys from just about 15,000 nursing homes nationwide. So we had 4 kind of outcomes that we were looking at all around deficiencies. First, we looked at just deficiencies overall. We categorized them into 3 different categories as well. So quality of care, quality of life, and also administration related deficiencies. And then we had 2 different measures for each of those categories, just an overall number, so a simple count, as well as a severity assessment. So you assign whatever grade they had received as far as severity, a certain number of points, and then you sum that up. Our main predictor variable of interest was this binary: was an ombudsman present during the survey or not? So that was just yes or no. And then we had a certain amount of covariates that are important to include in the model. So at the facility level, we included ownership status, profit, not-for-profit, facility size, so the number of beds, whether or not they were part of a chain of nationwide or statewide nursing home chain, whether they were part of a continuing care retirement community, CCRC, their occupancy rate, their payer mix in terms of Medicare versus Medicaid, their resident case mix as sort of an indicator of how ill or how significant the issues were that they were dealing with in terms of resident health, and also staffing levels for nursing and all of the direct care workers. We also had some county level covariates in the models as well, the number of facilities within a county, whether or not HMOs, Medicare Advantage organizations, how prevalent they were in the particular region, and also per capita income as kind of a proxy of resources available in that particular county. So one of the main issues, or really the main issue that we had to deal with when we were conducting this analysis, is the issue of confounding. It just kind of stands to reason that ombudsmen may go more frequently to nursing homes who have persistent poor quality. That's where they're needed most. That's where perhaps the most issues are. And so they're trying to use their resources wisely, and they may go to those facilities that have more consistent issues and consistent problems. If that is true, then ombudsman presence becomes highly correlated with just an indicator of facility quality, instead of representing just the ombudsman presence by itself, independent of quality. If you were looking at this issue in more of an experimental design, I mean, what you would want to do as sort of the gold standard, right, is randomize which facilities the ombudsman goes to during the survey or not. And then you could kind of disentangle whether an ombudsman was present from whether or not the facility had sort of a high or a low quality rating. But given that this was a secondary data analysis, the surveys had already happened, the ombudsman was either there or they were not. So we could not, retroactively go back and randomize who or what facilities the ombudsman were going to go to. So it just wasn't feasible given the data set that we had. And it, in the real world, I don't really know how you would engage in that kind of study, because ombudsmen should be able to go to whatever facility they want to, rather than being randomized to a certain set of facilities. So in order to account for that, we used a facility fixed effect model, so that this was an uncorrelated variable that was uncorrelated with whether or not the ombudsman was present. We used a panel regression technique because this was repeated measures data. And that allows the ombudsman variable to be quasi-random, so to act independent of quality, because the quality issue is absorbed by the facility fixed effect variable. And I'll talk a little bit about how that works here. So first, we needed to establish that this confounding is actually occurring, that it is an issue. So is ombudsman presence confounded with quality? Here we fit a model where deficiency outcomes from a prior survey were used to predict whether or not an ombudsman would be present at the next survey that that facility had. And when we included only state fixed effects to account for differences across state, there was a statistically significant relationship for both the number and the score of deficiencies. So whether or not an ombudsman or whether or not a facility had a higher number of deficiencies or more severe scores on those deficiencies was related to a greater chance that the ombudsman was going to be present at the next survey. So it does seem like ombudsmen are more frequently or more often going to those facilities who are having some issues, some persistent quality issues. When we changed from a state fixed effect to a facility fixed effect, that statistically significant relationship went away. So now there was no longer a significant predictive relationship between historic survey performance and whether or not an ombudsman was going to be present at the next survey. So all of that quality confounding was absorbed by the facility fixed effect. And so whatever was left in the ombudsman variable was just the presence of the ombudsman independent of any kind of persistent quality concerns. So now we can feel more confident that whatever effect we might detect around the ombudsman variable is just because the ombudsman was there, not because the facility had higher or lower quality. So what results did we find? So whether or not an ombudsman was present at survey varied quite extensively across state. The minimum number was less than 1%, which I believe was in New Hampshire, which you can see in this abbreviated table. At 0.8% of the time that there was a survey going on a facility, in a facility, the ombudsman was actually present, to a high of 82% in Maine. So I'm not sure what's going on in New England, but they have the opposite ends of the scale up there as far as whether or not an ombudsman was present during a facility survey event, with an average of 29.9, around 30% of the time an ombudsman is going to be present at a survey. So for our regression analysis, when we included the facility fixed effects to help with that issue of confounding, and also all of our other controls that I mentioned, there was a significant relationship between whether or not an ombudsman was present. It resulted in a 3.9% increase in just the overall number of deficiencies that were received in a survey, as well as a 5.9% increase in the deficiency scores, so the severity of those deficiencies that were given. Just as a statistical check, we also included a variable to account for if an ombudsman had been present at the prior survey. Again, just to reinforce that this wasn't just a persistent quality issue, but that it really was an independent effect of the ombudsman presence. And that did not change the pattern of results. They were still statistically significant and still associated in the same way with an increase in both the number and the score of deficiencies. When you broke it out into those three categories, the largest percent effects were for quality of life deficiencies at 6.3%, and also administration facilities at almost 9%. So what does this mean? I mean, ombudsmen are a vital partner and advocate, as both Ken and Dana said, for residents that are living in long-term care. They're very essential to making sure that the resident voice is heard and that resident concerns are addressed. But we were able to demonstrate that how the ombudsman program is realized and supported varies widely from state to state and also even within a state. So ombudsman presence at a nursing home survey can impact its outcome, which can have severe consequences for that particular facility. And these impacts persist even after controlling for historic quality levels and other factors that might be associated with that. Some limitations to keep in mind when thinking about the results of this study. The results only apply to whether or not an ombudsman was present at the current survey. So it does not address whether or not these issues were corrected. It does not address any kind of trends over time. It's only survey deficiencies as far as the outcome. So it does not look at complaint data or other dimensions of quality, such as resident or family satisfaction. And it was just an indicator of yes, no, the ombudsman was present. And we really didn't have any information about what that ombudsman might actually do during the survey process. So we don't have anything that we can speak on as far as what was their actual role while the survey was happening, only that they were present and that it seemed to have an impact on the outcome. So take-home messages, we should strive to fully support the ombudsman program across the state and across the nation. And we should work to ensure that the survey process for nursing homes is applied consistently across facilities to help ensure the highest quality of care for the residents that live there. These are my references, with the bottom one being the actual article that I was talking through, published in JAMDA in 2019. And now it is time for questions. Thank you so much.
Well, thank you so much, Dana, Ken, and Diane, for a fabulous panel presentation. We were able to hear more about the role of the Ombudsman with some specific programming from Dana. Ken, thank you so much for sharing some of the important legislative pieces and requirements of the role. And then Diane, what an interesting study that provides some important things to think about and discuss. So before we get to some of the questions that we have written in the chat or the QA, and we remind people to put your questions and comments in, and you can also raise your hand if you want to be unmuted to talk aloud. I wondered if Ken or Dana or Diane, if you wanted to kind of react to what one of the other presenters shared. I'm sure Dana and Ken, as you were listening to the study that Diane was presenting, you may have some interesting questions or insights. So I thought we'd start with that.
Well, from my perspective, I've got to say that whatever support and whatever we can do to help seniors be experience the best quality care that is possible, we definitely need to be involved with that. I appreciate the purpose and scope of this research, because it's obviously directed towards trying to measure, is there a response, is there a way that when the ombudsman's there, there's some measurable effect. And so I'm encouraged to know that and to see that in this research. I think intuitively we knew that previously. I think from Dana's perspective, she's the one who sees these people personally, and it can be very satisfying to help resolve problems, but it is also at the same time can be very frustrating if you're not able to improve quality or to get things rolling in a positive direction. And we're really challenged as a long-term care continuum to provide what's necessary for seniors across the nation because of our lack of caregiver resources and because of other factors. And so we need to be as sensitive and as positive as possible to provide any support that we can for our community of providers.
Yeah, so trying to find that balance between supporting the individual or group of residents, but also being aware of some of the barriers and challenges that the providers have as well. So yeah. Dana, do you want to comment or react to what was presented as well?
Well, I think as far as the role of the ombudsman, so much of it is empowering the residents to speak up and have a voice. So I think we spent a lot of time as ombudsmen talking with the residents about their rights, attending residents' council meetings, and just sharing with them that, you know, you have the right to speak up, that you shouldn't be letting something go that's important to you. And they can be the smallest things that can really make a big impact in their day and their life. And this is their home, and they need additional help. And that's where, you know, it comes to the advocacy and support of the ombudsman. One of the things that I think is really related to Diane's study is that prior to an inspection, the staff ombudsman, get an email from the state and informing us that they are going to be entering a facility. And at that point, they ask us to share with them survey or concerns, issues that have come up through the work of the ombudsman. And of course, that is confidential. In fact, confidentiality is at the highest, you know, level when we are dealing with residents' concerns, and everything that we do, we take resident direction from. But at that point, when we get that email, or I receive it, we can go into access. It's called Ombuds Management System, and that's where all the information that is gathered is entered. And so I can search a particular facility, specific dates, and look at all the cases, look at residents' council minutes, and then I can share that with the state and correspond with them, whether it's over the phone or through an email. So I think that piece of the work of the ombudsman has in the state inspection is key. Not that we couldn't be present during that, but I think prior to them going in, that they then have a sense of what to look for and where the questions to ask the residents. Another part that we do is we are able to attend the meeting with the state inspector and the residents, and that is a closed door meeting. There is no staff present at that meeting, and the residents are able to share their concerns in a closed, secure, basically, setting. So I think that the whole program, I think, really benefits, you know, the residents, but they do have a difficult time speaking up out of fear of retaliation.
Yeah, and I want to kind of follow up with that in terms of the resident council meeting, which is a little different than the meeting you just described, Dana. But I think all three of you have had experience with resident council. And as a former DON, I'm familiar with a certain model of implementing a resident council format. But I know that I've been in other tier communities where, for example, people are set up kind of in classroom style, and administrators and DONs are actually in the back of the room as the resident council meeting is. Could, you know, maybe if you could share what are really best practice approaches for that type of meeting with residents.
Did you want me to answer that question?
Sure.
Oh, okay.
And
I've seen many different formats of residents council. I think that there needs to be a balance. I think that often the residents can request the format that they like to have. I think that often when there are specific staff in attendance, that often the residents aren't as forthcoming with their complaints or concerns when certain staff members are present. So I think that that there really needs to be a balance. I think that it's nice when, you know, and this doesn't always happen, when you have one or two, you know, you have these facilities where you have residents that have a lot of cognitive, you know, problems and issues. And so you have to have one resident that can be empowered and supported to lead a residents council meeting. And that can, an ombudsman can help with that. A social service coordinator can help with that. An activity professional can help with that. So I think that my light just went off here. Hold on one second. I think that, you know, it's to trial and error to to see really what works for a specific facility and group of residents.
I think to kind of go off what you were referring to or kind of talking on before, Dana, Liza asked, are there any complaints that the Ombudsman addresses in long-term care that's public knowledge? And if it is, can it be accessed over the internet or in records?
I missed what you said. Can you repeat that?
Sorry. Liza asked, are there complaints that the Ombudsman addresses in long-term care, and are they accessible to public knowledge?
I'm going to guess that everything is held in strict confidence as far as what is shared during residents' council meetings. That it is a confidential meeting.
Okay. Another question I saw pop up was one that I think we're all probably very interested in is how have things changed over the past, several months or almost a couple of years in relation to the COVID pandemic? It's probably a pretty big question, but Ken and Dana in particular, can you comment about how that has impacted the role of the Ombudsman, maybe the different types of complaints you might be receiving from either residents or family members? How has it impacted your ability to kind of hear those complaints and process those and work on improvements? What are your thoughts about that in relation to the pandemic?
Well, I can say that our Pennsylvania long-term care ombudsman program has been awarded recognition in their responsiveness during this COVID outbreak. However, nonetheless, COVID did have its impact. We did experience times when access was limited. There were practices in the facilities that came about as a result of COVID that wasn't the usual kind of practices. For example, family access to residents was different during COVID than other times. So there's no minimizing the fact that COVID has been a devastating event in our society, and particularly with seniors, and also particularly for the seniors who find themselves during this time in a long-term care facility. Nonetheless, I'm proud of the fact that our ombudsman program and the state ombudsman program has persevered, and we've worked towards maintaining access to residents and hearing the types of concerns that they have, and advocating on their behalf and empowering them to express their concerns. And so it's just we're bearing up, or at least during the height of the COVID pandemic, we're bearing up under difficult circumstances. Things seem to be emerging, and we seem to be doing better now. And we certainly have better access and are more able to help empower seniors now.
Okay, thank you. We'll take another question from the Q&A.
Between Penn and Dana, do you notice a theme between key issues that patients and families arise during that ombudsman process?
I couldn't catch the question.
Do you guys have noticed any kind of theme or consistency in terms of complaints between the patients and the families?
Yes. One of the biggest ones is basically having access to the visitors. The visitation policies have been really fairly strict. So we get a lot of complaints about that. Getting a lot of complaints about staff shortages. Those were, I would say, those would be the two biggest ones.
Diane, can you share with us some ideas? You mentioned some of this, but I wondered if you could expand on some ideas about how you would take your research to kind of the next level, what kinds of things you'd like to explore further. And
yeah, thanks, Janice. I think it would be really interesting to look at these trends over time to see how ombudsman presence might change survey results from year to year. And also if there was a way to encapsulate some other measures of quality outcomes, you know, like I mentioned, patient and family satisfaction, or the complaints issues, like Dana and Ken have been mentioning, as well as a little more richness about what the ombudsmans are doing during, you know, the survey and leading up to the survey process. Again, to just expand beyond that simple binary, were they there, were they not there? You know, was the information provided ahead of time? How much information, you know, did the state surveyors actually take that into account and use that to prepare their work? I'm not quite sure how you would go about getting that data, but it would be awesome if we could. So yeah, just trying to paint a little bit sort of more expansive and richer understanding of exactly what's happening during this whole process, I think would be really interesting.
well, I'm afraid we're running low on time, but on behalf of the CGNE leadership team, I'd like to thank all three presenters for an outstanding presentation, as well as some great dialogue. And I wish we had a little more time to continue our conversation, but hopefully we can in other venues. So thank you again to Ken, to Dana, and to Diane for sharing the important role of the Ombudsman and how important the partnership is in long-term care, as well as other services that provide care for older adults. So thank you so much for all the information and intriguing conversation today. As a reminder to our participants, although the evaluation tool is required for RNs seeking contact hours, we do ask that everyone complete the evaluation within 1 week. The link has been put into the chat for your convenience. You can either click on it or copy and paste it and complete the evaluation now, or it will be emailed to you within 24 hours, and you can complete it again within 1 week. Thank you again for everyone attending today. We appreciate you joining us for this great seminar, and we hope to see you in a couple of weeks. Have a good rest of your day, everyone.
Thank you.
Thank you.